Hi, Tim.
Patrick, thank you so much for. So let's go in terms of, because what I'm picturing is, the average aesthetic nurse in the UK is by herself in a clinic without very many clever machines to help her,
Sure.
and she's got a VO.
Yes.
What would you say would be a reasonable thing to do? Because I think it's incredibly high stakes for that person at that moment
Sure.
to not
I get a
go
lot of
see.
those type of proceduralists. I say the vast majority of the people I get are nurses from Britain. I know I get people from Australia, Saudi Arabia, India, and all the rest, but that is a target market. And you're right, they do feel isolated, and they're sort of. And I'm sad to say as well that sometimes, not so much now, but certainly in the past, I suppose, since people know how to do this, they turn to colleagues, particularly in the British College, for help. So the first thing is, I suppose, not to panic. You have control over it, unless, and I got a really bad Lancet one today. Unfortunately, I suppose the first thing is always use hyaluronic acid when you're near a vascular lesion. I'm an advocate, as you know, over the years of bioalchemid, originally for HIV, for the calcium hydroxyapatites and all the forms. And these have wonderful uses in certain areas. But if you're near an accident or a major vascular structure, particularly an artery, infraorbital, facial, transverse facial, I think only hyaluronic acid should be used. So the fact that you have got hyaluronic acid means, and you've hyaluronidase with you, your panic is almost over. So the first thing is obviously to agitate the tissue to see where the embolus move on, warm the tissue, maybe if you've got a microwave or a hot tap with some warm gauze, and start your, I suppose, capillary count to see what sort of trouble you're in. There's no problem at any stage, sort of getting in touch with myself or you, for a colleague to be, sort of there to help them through this in front of the patient, because the patient can read their face also that there's trouble happening. So what I normally do is this, Tim. I get a good hard pule. I take bacteriostatic saline and I make it to 1 ml. Then I withdraw 0.5 from that, and I withdraw bacteriostatic saline. So each one then in the 2 ml has got 1500. So each 0.1 is 75 units. So I can use the 1500 straight away, or I can do it as a split thing to get the patient to come back within 24 hours. I know where the vessel is, and don't forget also not only the proximal distribution, but the sort of distal one, to track it and sort of, just go around it, 10 shots, 75 each time, and leave it sit. If it doesn't clear, it will clear, and that's where you have to sort of stop the panic at the time and bring them back and do it, sort of 12 hours later. Always be on the end of a phone, have the patient being able to contribute anytime, and expect it to get worse before it gets better. You can look at these after a while and say, listen, this is going to get worse for the next 2 or 3 days. Don't panic. And then you'll see a turn in this, and the tissue will begin to come back to its normal color. And most of them clear in 5 to 7 days. But the thing is, if you keep pumping hyaluronidase into it, you probably won't see the tissue magically coming back to normal. But, for the person starting off, it's a difficult thing. Lewis Hamilton can go out and win the Bahrain Grand Prix because he knows every corner on the course. But somebody starting for the first time doesn't know what's ahead of them, so they're going to be sort of slower. And as a consequence, when they get some under their belt, they can easily turn around the page and say, you will be fine. Don't, sort of too worried about this. And also, if they want to contact somebody else, don't stop them doing that. If they want to go to the hospital, that they may get less sort of treatment there, to be honest. But that's fine. If the patient thinks you're hiding something, if the patient thinks you're compromising their potential, sort of problem to their face, that can turn legal at that stage. And I've been expert witness in a lot of vascular occlusions. I never go in against the proceduralist, and my house is always open as well, from the point of view that if beauticians come to me with problems, I never say you shouldn't be doing this. Some of them come with their own hyaluronidase, because I think as soon as you, sort of forget that the patient is the victim here, You can't, if you've done ER, I think you have, like myself, Tim, and you get a rapist in, you've got to treat them if they've got a heart attack. You can't be the moral police telling them you can be doing it in social life. And I think it's the same thing. I have a run of beauty therapists bringing in problems to me, and I never once would come around in front of them or the patient and say, you know, you really shouldn't be getting your hyaluronidase in from such and such. You've got a problem, deal with it. Once the patient is coming out the other end a week later or something, then you can say what you have to say. Because the patient probably will read the situation that they're in quite a lot of distress.
I'm in the situation where I'm picturing an aesthetic nurse in the UK who's done her 1,500 units. Yes. Is she waiting for capillary refill to return to normal before sending her patient home?
It's a very good question, and certainly my experience is that I haven't done that. I know that sort of some people would feel happier going to bed that night if cap refill was back, and you know, sort of not sitting at 5 to 7 or whatever. I've often let them home and see them the next morning and assume that, you know, sort of it's going to work overnight. So I've sort of taken those risks many times, and particularly if you're doing it on WhatsApp or you're doing it on FaceTime. I had a case in Lebanon, and last year, well, during the lockdown, actually, it was a really bad one, and we couldn't get cap refill to change at all.